itera pandemic. Only this time it really shifted and caused such huge pandemic situation. But normally influenza niyibikora, and that is why I chose this lecturer to explain how does influenza do this. So same, ngira ngo twabivuze ibingibi, and you as a clinician, it is very important kugerageza kumenya, ugerageza gukora clinical diagnosis neza, kubera ko sometimes respiratory tract infection zishobora kuva kuri viruses, zishobora kuva kuri bacteria, zishobora kuva kuri fungal. So they may be or they may come from the three type of pathogen which are not really closely similar. Kurugero hano cyane cyane muri lower respiratory tract dufite SARS, severe acute respiratory syndrome, the causative agent, tukagira immediately na coccidioidomycosis, which is fungal, tukagira na influenza, all affecting the bronchi. So we have pneumocystis pneumonia, we have all these, also histoplasmosis, which affect this. So in brief, we also have bacteria, as you see. We have pneumococcal pneumonia, Q fever, which is more related to and legionellosis. We have tuberculosis. We have Pathogens. I think we will see this. All these are more of bacteria. So dufite bacteria, tukagira fungal, tukagira viruses. We really need to differentiate what is what. We also, in the upper, we also have diphtheria and the streptococcal throat inflammation that can also be confused with common cold, parainfluenza, hepatitis B. So it's very important to really differentiate this, kubera ko kubivura biratandukanye. Ko wavura bacteria with antibiotics, the fungal will not be susceptible to antibiotics or viruses. So viral respiratory infection is most common in bana no mu bakuru. So is and fairly mild and remain confined to the upper respiratory tract. Kenshi iguma muri upper respiratory tract kandi ikaba ari mild, not very severe. Sometimes it spread downward and cause more severe, sometimes life-threatening, iranic. So, and most the viruses are transmitted by droplets. Hari n'izindi viruses zidatera ikibazo muri respiratory tract, ariko zinyura muri respiratory tract by shedding through respiratory, but also transmit through the respiratory tract. Izo ngizo ni nka measles murayizi, mumps, rubella, parvoviruses, varicella zoster, and many others, which we use the respiratory tract for transmission and shedding, but never cause problem in the respiratory. They just use the root to transmit, but also to evade the other part of susceptible organ, to attack the susceptible organ. So, tuvuze viral pathogens are respiratory infection. There is influenza, which is the main, and why we chose this to discuss. We have parainfluenza. We have which have of course sub type 1 to 4, respiratory syncytial virus, adenovirus, cytomegaloviruses, but not for for immunocompetent people, mostly for immunocompromised people. Rhinoviruses, coronaviruses, na human So let's start with the parainfluenza viruses, which has 4 types, antigenic distinct type that only affect human. So we see that contrary to influenza, parainfluenza only affects human, while influenza can have a wide range of hosts, affecting birds, affecting the pigs and other animals. So as a virology, parainfluenza and paramyxoviruses like measles, if the envelope is 2 glycoprotein, hemagglutinin na neuraminidase na F factor cyangwa F glycoprotein allowing cyangwa facilitating fusion to allow viruses get inside the cell. It causes respiratory tract infection in all age and mostly occur in childhood, more likely to be symptomatic, symptomatic, while immunity is poor, reinfection is common, spread, droplet and formant, and clinical symptoms, laryngotracheal bronchitis, bronchiolitis, pneumonia, infection, cause, common cold symptom. Dufite respiratory syncytial virus, twabonye ishobora muri cyane lower respiratory tract. It is also a paramyxovirus. It has envelope. It is single-stranded RNA viruses. That's the lack the glycoprotein twabonye kuri iriya yindi yaba H, ariko ifite fusion protein that allow the respiratory syncytial virus to integrate in the host cell. And it gets its name kubera ko infected cells zimaginga zigakora large syncytia. So ziramaginga zigakora
ahubwo bano bantu niba abantu banywa bagashira icyaka inzoga ugasanga irimo iragura 700 700 ni amafaranga.
Fusion zituma cells zifusing then zigakora one giant cell ariyo twita syncytia. So it's spread by respiratory droplets and fomites, similar to previous bronchiolitis, bronchopneumonia, especially in younger children. And vaccination or vaccine attempt not feasible. Guhera muri 1960. But up to now, vaccine really effective. We have also human metapneumovirus, which also lacks hemagglutinin, single-strand RNA virus enveloped, but of course contain fusion protein. It is also subgenus of paramyxovirus. It's also a paramyxovirus. It caused seasonal epidemic, R spring, of course, in many Western countries. and same way of transmission and similar, more or less similar symptoms to the previous. It can also cause common cold and re-exposure. It doesn't provide or induce longer immunity, and it can cause problem in adults, especially elderly, bronchitis. So we have adenoviruses or adenovirus, which is in adenoviridae, polynuclear enveloped, icosahedral double-strand DNA. This is the class 1 Baltimore classification, and it has several types, up to 41 human adenoviruses, which are now divided into 6 sublineage, A to F, as you can see here. And sometimes subgroup are linked with a particular clinical manifestation, like those that affect only GIT, gastrointestinal tract. You can see some can only, like E, subgroup E, we only affect the upper respiratory tract with eyes. So these are what is now known, but 41 human adenovirus is many. It is throughout the year. It doesn't have seasonal, and transmission, droplet, formaldehyde, and ingestion, especially for those GIT types, subtype of adenoviruses. It can also cross the conjunctive membrane, mucous membrane. And, most infections remain localized to the body surface. They don't go in and are asymptomatic. And acute are mostly self-limiting, so they will cure. So we have asymptomatic infection, which is the most often. We have acute pharyngitis with fever. We have pharyngoconjunctival fever. We have acute follicular conjunctivitis, and all these are So we have rhinoviruses, which is more frequent, or the most frequent cause of common cold. So it is in picornavirus. Who can tell us what other virus did we find in this family? Ninde watubwira indi virus twabonye muri iyi family? Picornavirus. No? You have to read. So it is a small
Hepatitis A virus.
What?
Hepatitis A.
Yes, mubyumve n'abandi. So hepatitis A iri muri family as rhinoviruses. So it is not enveloped, single-strand RNA with many antigenically distinct serotypes. Bituma more than 100 antigenically distinct serotype bituma umuntu yagira reinfection y'izindi strain inshuro nyinshi. Bivuga ko niyo mpamvu umuntu arwara grippe muri same season akongera akarwara indi, because it comes from a different antigenically distinct serotype, and it causes common cold in child. It may cause lower rare. Common cold syndrome. So for approximately 50% ya common cold iterwa na rhinoviruses. Hanyuma hakaza coronaviruses ifite two serotype igira up to 10% za common cold. Other viruses cyangwa other antiviruses harimo na respiratory virus na parainfluenza nizo zadinga up zikakora indi 40% kugira ngo 100% ya noze ibe justified. So we have this, which also caused the pandemic. The pandemic, I think, 2002, severe acute respiratory syndrome, SARS, and it caused acute viral lower respiratory tract infection with a high mortality. So it is very, very serious. And it was also caused by a novel coronavirus. And first case occurred also in China, Guangdong province. So it's really how people interact with animals, the animal-human interface. I think that is really something to consider in this region. As a result of poor infection control measures, the infection spread to other parts of the world. Take a pandemic, nubwo katari strong in COVID dufite nonanga. Incubation period 2 to 10 days, and all these symptoms, starting from a prodromal of fever, myalgia, malaise, and up to serious. This is followed by lower respiratory phase, dry, non-productive cough, dyspnea, and hypoxemia. Require ICU admission. It was really a serious and was killing. So from less than 1% in patients less than 24 years, but 50% in patients greater than 65. And the mode of transmission was not quite clear. Respiratory droplet, of course, and fomite, but stool also, fecal oral route. Effective infection control measures, including hand hygiene, contact precaution, eye protection, environmental cleaning, and of course, N95 mask can be helpful to protect against infection. So iki nicyo cyatumye twiga cyangwa tunyura muri iyi chapter ni influenza virus or flu, iyo twita flu muri noze. So is a respiratory tract infection caused by influenza virus, which is able to mutate. This mutation is most important to cause pandemic. Turareba how does this happen? The most infamous is 1918 Vita Spanish flu, which caused a death of about 50 million. This is a very, very huge number caused by one pathogen in particular time. So it is in family of orthomyxovirus, tukagira subtype SHA2, A, B, C, and single-strand RNA virus with segmented genome. This is a picture of the I have no kuvuga ngo virus ifite segmented genome, ifite segment 1 to 8. 1, 2, 3, 4, 5, 6, 7, 8. And each segment, of course, have to go with the enzyme, RNA dependent RNA polymerase, cyangwa icyo twita replicase, that will allow the replication of this genomic virus. So it have segmented genome. It is enveloped and has this H, hemagglutinin, na N, neuraminidase. The H is responsible for viral attachment on the cell, and the N is responsible for viral exit from infected cell. Nukuvuga izi antigen zombi zirakenewe cyane, imwe muri entry indi muri exit. So influenza ariyo type kenshi iza muri pandemic and can be further subtyped according to its H and N group. Nukuvuga izi ni antigenic. So izi group nazo twazi groupinga. There are 16H type, serotype cyangwa antigenic type, na 9N type cyangwa neuraminidase type of influenza. Noneho hakaza combination yazo. But only H1, 2, and 3 are for human. No, na N1, na 2 subtypes circulated in human. Nukuvuga izindi beyond izi is 16 from is 13 is circulating muri animals, birds, and so on. While N as well, only 2 are related to or circulate in human. So both H and N are important antigen used in the vaccine formulation. So they are very useful muri vaccine formulation. Iki twakibonye dufite as usual envelope, glycoprotein envelope, tukagira capsid which is in here, dufite za H, hemagglutinin, zizafasha muri attachment, tukagira na neuraminidase cyangwa N, zizafasha muri release cyangwa exit from the infected cells. Hanyuma imwe muri each of the segment, we have 8 segments, and each of the segments is always with RNA polymerase, with which we help these viruses to replicate. And this is what would what polarity is this virus? Mwavuga polarity yayo given its structure. Twavuga polarity yayo? No? So I'm informed that your tests have been shifted a bit earlier. Bambwiye ko yigishwe hino. None ubwo muri tayari murayiteguye neza?
No.
No? No, I'm asking the question about the polarity of influenza, as you have seen the genome configuration.
I can say because that RNA dependence polymerase is negative polarity.
Why? Why is that? Where iki twavuga on negative polarity? Where iki twavuga ko ari negative polarity? No answer?
Due to the RNA polymerase.
What? Ubwo kuvuga ngo ni negative polarity tuba tuvuze ngo iki? tuvuze ngo ni negative polarity tuba tuvuze ngo iki?
Polarity means the sense of the DNA or RNA.
Okay, sorry. So ubwo tuba tuvuze ko itari able of
Translation.
Yeah, I hope you all know that. So as clinical presentation, it spreads by droplets, intubation in 2 to 3 days, and flu is primary respiratory tract infection, but also are common. Kuvuga ngo bigarukira hariya gusa. Can you please turn off your mic? And some difference between flu and common cold. This is more obvious. Influenza cyangwa flu izagira more systemic, while common cold iri local, mostly local. Spread irihuta, while this is gradual. Usually high fever and usually low grade. Ibi byose murabizi, yaba common cold, influenza, I don't know it, but you must at least once in lifetime have the common cold, so you know all this. And influenza is more seasonal, while Hano is throughout the year. And the risk of more severe influenza symptom are more pregnancy, chronic pulmonary, cardiac or renal disease, cyangwa abantu bakuze cyangwa abana cyane. It is more common in temperate region, in European country, iragira cyane. And it's between April and September for the southern hemisphere. A very few decades, a new influenza strain emerged. Infection million of this is called a pandemic. Turaza kubibona ko nihiva kuki ko buri gihe tugira pandemic ivuye kuri new influenza type cyangwa new influenza strains, and this is always causing the pandemic. Kubera ko abantu bataba bafite immunity kuri yo, biroroha ko abantu bose igezeho barwara bakanatransferinga infection ku bandi. And individual can suffer repeatedly kubera ko influenza antigen structure is highly variable. And we have two important evolutionary mechanisms that allow the variation of antigen in influenza. And now we have a few years hakaza a new strain ituma habaho pandemic. So hari icyo bita antigen drift, which take place in both influenza A and B, and antigen shift only for influenza A. So what happened with the antigen drift? This is the minor changes of genomic configuration, and similar to other viral pathogen, because this replication enzyme have the errors, and by introducing the errors, mutation that is point mutation that may appear in a region, genomic region, a particular genomic region, ivuye kuri errors, ivuye kuri replication, and that is drift. While shift is something else. Normally, nkuko twabibonye, genome ya influenza ni segment. So sometimes when two types of influenza viruses zihuriye muri cell imwe, ni ukuvuga ngo hari cell iba infected na influenza A y'ubwoko bumwe ifite H na N bitandukanye, n'indi infecting the same cell ifite H na N bitandukanye n'iby'iyo ya mbere. In that case, nkuko twabibonye, habaho it first fuse, then the viruses kajya muri cell, hanyuma ikagira replication, yarangiza kugira replication hakaba assembling, hanyuma hakaba release. So during assembling birashoboka ko kandi binabaho kenshi ko za type zombi kubera genome segment zose ziba ziri muri cytoplasm, ziba called muri capsid imwe kandi atari zimwe. Ni ukuvuga ngo hakabaho exchange, reassortment ya genetic material. Ni ukuvuga ngo za fragment iyari kujya muri one type zikivangira muri capsid imwe. Icyo gihe automatically havuka a new virus with new configuration of antigen, and that new virus will not be known muri host, yaba host ya mbere yaba na host ya kabiri, ko izaba ari nshyashya. And that is how the flu pandemic comes or we just emerge. And this only occur with influenza A, not B, not C, or para-influenza ntabwo ibikora. Kubera iki? Kubera ko tuzabona ko A ariyo yonyine ijya muri different type of hosts. Any question here? So drift in minor antigenic change, point mutation, they were introduced during replication, and drift result in annual epidemic of influenza A and B in human. Kubera ko haba habaye antigenic change, iyo antigenic change ibitazwi muri iyo population, ariko haba harimo similarities nyinshi ku buryo idakwirakwira globally, itajya ahantu henshi. Ariko iyo habayeho major change ariyo antigenic cyangwa shift, ni ukuvuga haba habaye reassortment ya za segment uko ari 8 each normal virion igomba kuba ifite ziriya segment 8 1 to 9 to 8 ariko ntabwo necessarily ya sortinga each of the type uburyo niba ziri muri cell imwe niba ziri muri cytoplasm imwe iba called separately from each type to each type. So sometimes the result is a combination of two genomic fragments. Iyo bibayeho gutyo nibyo twita reassortment, nibyo twita major antigenic change, iza resultinga muri completely a new strain, a new influenza strain. Iyi new influenza strain mwarazumvise H1N1 nizatera flu pandemic kubera ko globally iyo ntabwo yarizwi, so hosts ziri susceptible we completely transmit, we get sick and transmit the disease. Is that clear? Birumvikana? No? Turi kumwe? Students, are you there?
Yes.
Oui.
Yes, you are.
Nabyumvise cyangwa dusubiremo?
Yes.
Okay. Bambwiye ko mutajya mwumva kuri call ngo mukeneye physical kandi physical ntabwo yoroshye. What?
You have not yet understand. If possible, you can repeat for us.
Hari uwamufasha mu sister kubisobanukirwa. Let's see here. If you can see here, dufite a pandemic in 1918 yitwa Spanish influenza. Sibyo? Spanish influenza yari ifite configuration H1N1. Do you follow? And it emerged from an influenza strain of bad human. Urabyumva? Kuvuga ngo habayeho recombination ya so habayeho recombination ya bad influenza and human influenza bituma iyi barrier iba crossed. Sibyo? Tugira iyi and all its genetic segments thought to have originated from avian influenza virus. Ukuvuga ngo one kugira ngo iyi avian influenza ishobore kuinfectinga umuntu nuko already iba ifite some of genes zizatuma ikora appropriate hemagglutinin ishobora kwatachinga kuri. So let's say H2 and N2 influenza virus icyo bita Asian flu yabaye iki gihe yavuye kuri avian virus H2N2 na human virus H1N1. Iyo zihuriye muri seri imwe habaho reassortment, nibyo twavugaga niba za segment zuzuye muri cytoplasm. Muri during assembly ntabwo hariho specific attraction ya capsid na specific segment zishobora kwivanga. 3 new genetic segments from avian influenza virus introduced HNPB1. So these were new and were not known. Contained 5 RNA segments from 1918. No kuvuga ngo ya yindi dufite hano irongeye ikombininze n'indi ya avian. So bihise bikora a new virus. Iyi new virus isikora pandemic. Hano naho dufite the same new virus H2N2 human virus igiye kugira na avian virus H3, hakabaho reassortment igakora gutya. Noneho Hong Kong influenza, iyi nayo ni pandemic yabayeho. Noneho tukagira is it something that we reassort this one and the avian influenza again? Ngira ngo swan flu murayibuka. Swan flu H1N9 was also a result of reassortment. Ni ukuvuga ngo igihe cyose habayeho reassortment, ni ukuvuga one cell infected by 2 different type of virus, reassortment ituma havuka new strain izaba itandukanye na both the original strain, and will cause the pandemic.
Hi guys, I'm
susceptible
Ugandan.
host
I'm American.
have
And we are
busy
doing
have
accent.
busy pathogen. Is that clear now? I hope so. So same story. So we have hemagglutinin, neramidase from either the bats or the pigs. Yes.
I need about the drift.
What?
How the drift become affect the influenza to become pandemic.
The drift or the shift?
No,
Drift
drift.
drift cannot lead to pandemic. It may cause epidemic. Muri population iri limited, ariko ntabwo izalidinga kuri pandemic. Kubera ko ni minor changes. We are still having the same strain. Izindi antigen zose zirasa, bizatuma hari na host zimwe zitaba susceptible, zitarwara. Kubera ko only few changes happen. So some hosts we of course get sick kubera ko ya mutatinze, harimo point mutation. Some others will not because of the strong immune system built from previous infection. So drift may result in epidemic, kwa kundi abantu hafi ya bose baturanye bari mu gace kamwe barwara ibicurane, bagira flu. Hari nabyo kenshi dukunda kugira inaha hano iwacu bya za flu ziri mo and this is a bit different from the shift. Muri drift, kubera izi changes zitaba ziri major cyangwa zitaba ari nini cyane, bituma host zimwe na zimwe zitaba susceptible. Ariko iyo changes ari nini, ari new strain, most of hosts will be able to transmit. Ni ukuvuga ya break ya transmission niyo restrictinga ya pandemic nature tubona muri new strain cyangwa new flu pandemic strain.
Thank you.
So we have these, they are both susceptible, sometimes human and avian. Human strain, avian strain zigahurira muri pig, pig igahuza zimwe zikinfectinga single cell, noneho za infectinga single cell zigakora iriya reassortment, then the result hani naho havuye ya swan flu H1N9. Ntabwo muyibuka 2009, ngira ngo benshi muri mwe mwari bato cyane, ariko habaye a kind of pandemic itarabaye nka covid, ariko nayo yari treat global health. So this is all about this. Why do we not have influenza B pandemic? So far, no shifts have been recorded, no animal reservoir known. Kuva nta reservoir ya animal izwi, so then nuze nta. So they are same. Ntabwo dufite variability muri HN. Past antigenic shift zizwi hari nka Spanish influenza muri hisha abantu benshi, ibyo twavugaga H2N2 Ajan yica abantu benshi, H3N2, H1N1 emergency, no pandemic in 2009.
Question?
Yes.
I'd like to ask what that number indicates, meaning H3N2.
Who can explain that? Ninde wamusobanurira? Ninde wamusobanurira? Iyi mibare ivuga iki? No? Ubwo se twaba turimo twiga niba mwese mutabyumva. Barabaza ngo H2N2 bivuga iki? H3N2 bivuga iki? Ntabwo mubizi mwese? Class? Yes? Yes, please. No?
I mean that these numbers like H1 and N1, there is the existence of the shift, because you said that like here on Spanish influenza where there is H1 and N1. H1 means that there is this enzyme comes from avian flu, and then N1 comes from human flu, and then once there is occurrence of this shift, they form a new variant called Spanish influenza.
Without talking about the shift drift, what does H3 mean? What does 3 mean? We know H is hemagglutinin, N is neuraminidase. What does 3 and 2 mean? That is the question. Not clear?
I mean, these numbers, these numbers from 1, 2, and 3, there is the type.
Yes, I think we have this here. There are 16 H type, hemagglutinin type. Tukagira na 9 N type. Yeah? And all these 16 H type ntago infecting abantu, similarly to 9N. Only H1, 2, and 3 infect human, and N1 and 2 infect human. Ni ukuvuga ko izindi zitarimo hano zinfecting izindi animals. Do you follow? Yeah. And
Yes.
some animals are also susceptible to human strain or human type. Iyo rero animals iri susceptible kuri human type, kenshi na kenshi reassortment ibera muri animals. Murabyumva? Kenshi na kenshi reassortment ibera muri animals. So, kubera iki? Kubera ko animal is susceptible kuri byombi, it is infected, then the combination reassortment ikaba yarangiza kuba kubera ko new strain yabonye some of genes zayifasha kuinfectinga human, iza crossing a barrier interface infecting a human, bitera ibibazo. Ni ukuvuga reassortment kenshi na kenshi usanga ibera muri susceptible host like pig, like avian, duck. So how do we diagnose influenza? So we have rapid diagnosis where we can do the aspirate throat or nasopharyngeal swab tukakora antigen detection. Immunofluorescence test cyangwa enzyme immunolinked assay, so tukadetectinga les antigens za influenza cyangwa tukakora RNA detection dukoze reverse transcriptase PCR. And iyi ngiyi izadufasha no kudifferentiatinga H1N1 from the seasonal H1N1 strain. Shobora kutwereka new strain. So there is virus isolation, which is not available for everywhere, so it is rarely available. Serology and it is a direct detection of and you can detect also antibody, but it will not give too much because many people would already have a reactive antibody test. Laboratory diagnosis, antibody assay, na kintu kinini bivuze kubera ko already everybody has the antibodies, so that means it is kind of useless kuyipima kubera ko it's universal, it is such common kubera ko abantu bayirwara kenshi. So detection of viruses niyo ingenzi cyane kenshi na kenshi by multiplex PCR. Rimwe na rimwe immunofluorescence detection of antigen cyangwa ELISA system. The control measures with the viral surveillance, which is very important, kugira ngo ushobore gupreventinga abantu bawe ni ukugira surveillance continuous. And WHO encourage the surveillance for influenza. Iri na notifiable, ni ukuvuga ngo igihe mubonye case mugomba kumenyesha WHO. There is a vaccination, we have some vaccine, and there is a antiviral therapy. Dufite amantidine, demantidine zikoreshwa muri za influenza. The strain isolated help to determine the composition of the vaccine the following year. Kuvuga ngo ni na byiza ko habaho isolation ya pathogen kugira ngo tumenye vaccine content. Though there is inactivated split subunit vaccine for influenza A and B, the available is normally equivalent to get H2N2 strain na A, H1N2 na B. And the WHO review this composition each year bitewe na n'iriya surveillance iba yakozwe muri noze. Treatment amantidine can be used as prophylaxis ariko yanakoreshwa as a drug treatment. Rimantidine type A only, amantidine type A, which is zanamivir for both. So you can have also other treatments for symptoms, raised lipid, antifebrile agent, and sometimes complication. You have to be aware and treat them appropriately. So it is key. Any question with respiratory tract infection? Ibi twabivuze kubera specifically influenza. And you should expect some question on this. Nabizi neza ko mwari kubisoma bikabagora kumva drift shift and how does this happen. Niyo mpamvu twafashe umwanya kugira ngo ntimuzasome izi slide bibagore kumva ahubwo tubi discussing. Hari ufite ikibazo kuri ibyo? Any question on this? No question?
I have a question.
Yes.
For the reassortment to happen, there has to be two viruses infecting one single cell.
What? Please come again.
For the reassortment to happen,
Gahongera utubwire ntago tukumva neza.
I was saying for the reassortment to happen, there has to be two viruses, two influenza viruses infecting one single cell.
Yego. Niko twavuze kubera ko zita infecting one single cell. Warangije ikibazo cyawe? Did you complete your question? Christine Bibian. Huh?
Yes, I completed.
And what is the question? Is it clarification? What do you want to ask?
Because you say that one virus must have, one influenza virus has 8 segmented genome. So I was asking if there has to be 2 viruses for the reassortment to happen. Because I thought that if only one virus infects the cell, those 8 segmented genome may become reassorted. I don't know.
Hari uwamusobanurira Christine Bibian? Anyone can explain how does the shift or reassortment takes place? Kugira ngo twumve niba mwabyumvise abadafite ikibazo. No? So Christine Bibian, to have reassortment takes place, you have to get 2 type of viruses in same or single cell. Ni ukuvuga muri cell imwe ya host hakaba harimo 2 type za influenza virus. Hakaba harimo H1N1 na H2N2 cyangwa n'indi. iyo zirimo zombi ziri muri single cell zikora replication cycle nk'uko tuyizi, hanyuma muri packaging, muri assembly, genome fragment ziri supposed kujya muri type imwe, some of segment zikahura n'izindi segment zo mu yindi type zikaba assembled muri capsid imwe kandi ari types zitandukanye. Niho hazava H1N2 cyangwa indi new strain. Ni ukuvuga aho tugiye kugira new strain kubera iyo combination. Strain ishobora guhita iba successful mu gutera pandemic, kimwe nuko yaba ineffective, yaba iri idafite iyo potential yo kongera ku infecting indi host cell kubera uburyo habaye iyo reassortment. But for reassortment to take place, nk'uko bivuga nawe, nuko ibyo bintu byombi bigomba guhurira muri single cell. Is that clear, Christy? And reassortment is basically the combining of different fragments. Antigenic shift ni ka iri special kuri influenza. Nta handi turi buyibone. Nta handi kuri viruses tuzabona antigenic shift. Ariko antigenic drift is common. It's point mutation nizo tugira muri viruses zose. Kubera iki? Kubera ko ziriya enzyme za replication ntabwo ziri genuine, ntabwo zifite proofreading mechanism ituma avuga ngo hano ni error twakosore oya. It's just read and copy. Is that clear? Christy, byumvikanye?
Ego.
Bitumvikanye byanumvikana muri teste, which is not far away from now. So this is influenza. We also have retrovirus. Variyo twagira isigaye human retroviruses. Izindi slides zisigaye kandebe niba ari byo twagize nigako. Yes, same. Ukuvuga izindi zisigaye you can read and understand. Ndatekereza apart from hepatitis viruses, we did gastrointestinal viruses, respiratory, which is more influenza, which have this mechanism different. We are also going to discuss human retroviruses. Ibindi byose bisigaye, it's just read and understand ko mufite sufficient package kugira mwumve content. So human retroviruses, slide also by Prof. Muvunyi. First, it infects wide range of animal species and cause variety of disease. Hazamo tumors, hazamo wasting and autoimmune disease, immunodeficiency syndrome, aplastic and hemolytic anemia. So wide range of disease, and they are all enveloped viruses with RNA genome. The name is mostly derived from the fact you cause an RNA-dependent DNA polymerase, a very unique and very special, as this was the discovery of this was the initial evidence that challenged the central dogma of molecular biology, how tuvuga ngo from DNA, RNA, protein. So now there is also a possibility from RNA to DNA. So this was the only way we knew it can be possible to come from RNA to DNA. And this enzyme converts RNA genome to DNA, which then integrates the DNA into the host chromosome. Ibi bintu bibiri ni ibintu bikomeye cyane kuri retroviruses. Ni ukuvuga ngo sorry, it converts first the genomic configuration, genomic material, RNA ikayigira DNA, then it integrates the double strands DNA, viral double strand DNA to the host genomic material, which is very important features. And of course, reverse transcriptase, kuri uku guhindura from RNA to DNA, it is associated na error, it is prone to error, and rapid genetic variation is a feature of this group of viruses. Ukuvuga iyi rapid genetic variation twayita ngwiki, twayita how can we name this based on our previous lecture? So they are very prone to
genetic drift.
Drift, minor changes. Bigatuma tugira variation nini cyane ya these viruses. So this is the diagram. So we have diploid genome. Diploid ni ukuvuga ni udukopi tubiri twa RNA, and this RNA nkuko twabivuze ibiri coupled na RNA dependent DNA polymerase, ariyo twita reverse transcriptase enzyme. Very important for these viruses. So ibifite tubiri dusa, buri kamwe kose kifite molecule yako ya reverse transcriptase. This is the capsid matrix, and to have glycoprotein ziyifasha kwatachinga kuri receptors no kwinjira muri cellule by fission, fission from without. And the genus is subdivided into 5 subgenera. Members of 2 of these genera cause disease in human. Arizo tuvuga delta retroviruses, HTLV type 1 and HTLV, human lymphotrophic virus type 1 and 2, and lentiviruses ariho harimo HIV1 na HIV2. So these are related viruses, all have this reverse transcriptase, all have this configuration of the. So genome organization, retroviruses zifite diploid genome, twabivuze, 2 copies of genome, and the genome code for at least 3 important genes. Harimo core protein, GAG, genes yitwa GAG, coding for core protein. Harimo POR, core protein na structure virion component. Harimo POL, which is more reverse transcriptase or polymerase, and ENV, which is envelope glycoprotein. Sorry. And they have long terminal repeat. Zirangiza kuri genome hariya. And this terminal repeat, they are non-coding regulatory sequence at each end of the genome, which are important in integration of the genome into host chromosome. So ntabwo zicodinga for a specific protein ariko zifasha viral genome integrating within the host chromosome and which also control gene expression. So most oncogene code for protein with growth promoting property. Of course, the gene inducing cancer, and cancer is more related or associated with growth promoting property. Growth factor nyinshi, growth factor receptor, or protein that control the cell cycle. And their expression can lead to uncontrolled proliferation of the infected cells. Amahirwe, fortunately, none of the retrovirus known in infecting have oncogenes. So, by'amahirwe ntabwo zigira oncogenes zinfectinga abantu. Arizo twabonye muri kategori ebyiri cyangwa muri subgenere ebyiri, delta retroviruses na lentivirus, ntabwo zifite oncogene. So, defective viruses. So, many animal retroviruses are defective. So they are defective as they lost their essential genes for replication. Ntabwo ziba zigifite genes za replication. And productive infection, if cell harboring virus is super infected with a helper virus, which can supply the function of the lost gene. Kuvuga ngo iyo yabaye defective, ikenera helper virus kugira ngo ibe yashobora kuba full no replicating. So dufite genus retroviral sequence. Aho tugira tuti some which even were integrated into germ cell DNA. Those are integrated in the germ cell DNA, so they can differentiate to all type of human cell and will be then hereditary transmitted. Niba uko bimeze usange at least 11% of human genome is made up of this endogenous retroviral sequence. Fortunately, is the 11% that retrovirus is endogenously present in our chromosome, zibazili defective and cannot replicate. They are just there and they are part of our genome, they don't replicate and so on. So brief, I think we have gone through this. Retrovirus is a life cycle, a typical life cycle. Nuko habaho attachment ku rugero rwa HIV, receptors za CD4, T helper cell, noneho zarangiza kwatachinga za glycoprotein zazo, hakabaho fusion y'iyi membrane viral envelope na cytoplasmic membrane ya cell. Yarangiza gufusinga, automatically capsid igahita iba released muri selile, na capsid ikareleasinga RNA in cytoplasm. Hakaza reverse transcription izahindura ya RNA copy into DNA, hakabaho second strand ya DNA. Then this is integrated to fit the enzymes very specific, guchopinga up hano ahari specific, zigashiramo akaga sequence integrase. Noneho akaga sequence ka viruses kari muri chromosome ya host cell gatangira kugira iki, gukora transcription, viral messenger RNA, then zikaba translated, all protein are synthesized, na za glycoprotein zikajya kuri membrane nkuko bisanzwe, then assembly ikabaho, ya capsid ikaba formed, genetic material zikajya muri ya capsid, then the virus exits the cell by budding. zinjira by fission from without cyangwa fission zikasohoka by budding. Budding zikaba released zikajya co-infecting izindi cell. This is a brief life cycle ya retrovirus. Of course, there are a lot of steps in between each of the major steps that we describe here.
Question.
So as yes,
According to this cycle, in those process of virus life cycle, from the point of attachment up to their release, it seems like the host cell remain alive even when the virus has already existed from the cell. So how this virus will affect the life of this host cell?
come again.
I have a question on this life cycle. According to these steps, from the point of attachment up to the release by budding from the host cell, there is no effect on the life of the host cell because there is no bursting apart from just replicating the virus, and after replication the virus exists from the cell. So how this virus will affect the entire functioning of this cell?
None se nibi serire wumva ikinyarwanda?
Yes.
So if this cell is only industry to produce messenger RNA, viral messenger RNA, and protein, viral protein, what will happen is that this virus will miss the essential component. Kubera ko ibindi byose iri kubikorera virus. Yabaye uruganda rwa virus. So izapfa kubera ko itarimo gukora essential structure zayo. Ariko not only that, iyo imaze ku expressing the antigen hano hanze, uri kuyibona hano kubera kuri infected, it will be quickly killed by immune system. Do you follow? So hari uburyo bubi. Hari immune system iza clearing the infected cell kubera ko expressing the antigen. Hari nayo ubwayo izaba affected kubera ko yabaye industry ya virus. It will not produce its essential component. Ahubwo irimo gukora za virus, iri dictated. Do you follow?
Yes.
So we will see that one of the mechanisms is leading a pre-apoptosis, induce apoptosis, or the cell can easily be killed by
immune system.
The immune system. But that is a good question. So the 56 human retroviruses harimo all infect T cell, murumva infecting a T cell, dufite HTLV1, twavuze ni human T lymphotropic virus type 1, izwi guteraho T cell leukemia na tropical spastic paraparesis, and we have type 2, which does not have a known pathology yet, and we have HIV1 and 2, zibaenye, tera AIDS, and recently hari izindi type ebyiri za HTLV 3 and 4 zabaye discovered, but no pathology have been yet linked to this. So with HTLV1, it has worldwide distribution, and more hyper-endemic foci in southwestern Japan, Caribbean, West Africa, and it spreads generally by blood transfusion and sexual intercourse and breastfeeding. Ubwo buryo transmittingamo cyane. And clinical features, mostly asymptomatic and never develop disease, but sometimes they may develop one of the following complications to T-cell leukemia, lymphoma, aggressive tumor of CD4 cell, which infiltrates skin and brain. So akenshi nta kibazo zitera, ariko for some people it can lead to a very severe form of cancer. And yeah, so unfortunately it is not tested as routine in blood transfusion, where ukuntu iri more common. Finally wazabura amaraso uzaha abantu, kandi kenshi na kenshi ari asymptomatic, nta kitwara abantu cyane. So it is also associated with myelopathy, this aggressive non-demyelinating spastic paralysis. So it can be also linked with infective dermatitis, uveitis, and laboratory diagnosis is specific IgG antibody kuri ELISA na Western blot, na Retrovirus DNA muri infected cells, white blood cell by PCR. HTLV2 nta disease iri associated nayo, ariko hari abantu yagaragayeho bafite cell leukemia, but no specific pathology is linked to this. So our main interest is HIV-1 and HIV-2, which are the major retroviruses dufitemo hano zatumye tunagira ngo tuyinyuremo. So it was first identified in 1981 among homosexual men in New York, and it was associated with severe immunodeficiency state, associated with severe opportunistic infection in rare malignancy, sarcoma, and in 1982, yabaye named acquired immunodeficiency syndrome, AIDS, and it was isolated in 1983. Muri 86 nibwo hagaragaye HIV-2 muri West Africa, niho iri localized cyane. So currently up to 34 million people bari estimated kuba bafite HIV, and more than 65% bari muri sub-Saharan Africa. Murabona ko itugeramiye, donc abenshi muri sub-Saharan Africa niho yiganje. So HIV is the major cause of AIDS. HIV-2 has lower virulence. Its infection has been widely or largely confined to West Africa. So ni fossa yayo muri West Africa, nta handi iragaragara cyane, although ikwirakwira nayo nka HIV-1. So it is a new disease. HIV is a new disease and is sought to originate from Africa. Kubera ko hari primates zigira the two types, ziba infected in a two type of similar virus, simian immunodeficiency viruses, ziri very closely to HIV-1 and NA2. HIV-1 NA2, so isoprimate ziba muri Africa gusa. For example, this HIV is closely related to CIV, simian immunodeficiency viruses strain that affects this kind of monkey. And while HIV-1 strain is most related to CIV strain that affects chimpanzee. So it is so that the CIV crossed the barrier and infected human in some unknown way, similarly to HIV-2, and genomic analysis suggests that the virus was only infecting human in 1940 mu gihe HIV-1 muri 1930. So it has high mutation rate. Twabibonye impamvu yabyo nuko iriya reverse transcriptase idafite proofreading, iri prone kuri error muri replication. Then we have subtype A to G. A to G zigiye zitandukanye muri geographical location, donc distribution géographique ya A to G, a subtype iri variable. Epidemiology, Rwanda first case zabonetse n'ubundi kare muri 1982, and the virus increased enormously, ku buryo for now tubara ko at least muri 2005 twari dufite prevalence ya 3.7. In 2020 RFA yatweretse kuri aba bantu 3.7 n'ubundi as compared to 2.2 in men. This is women who are more infected or more barutaho abagabo gato. And transmission is 3 by 3 means, and same as hepatitis B, but is much less infectious. Hepatitis B is highly infectious ugereranyije na HIV. So hariho sexual intercourse. One of the risk factor ni partner ufite other sexual transmitted disease. And we have vertical transmission, infection ishobora kuba in utero cyangwa during birth, which is the commonest, cyangwa sometimes breastfeeding, vertical transmission from mother to child, and exposure to blood, cyane mu ba drug abusers, needle ziri infected yo exchange, and it really affects this category. So cause of disease, tubara 4 phase, and it is a persistent infection, host, and only cause death many years later. Primary infection, most individuals experience a febrile illness muri 2 to 4 weeks after exposure, and it coincides with seroconversion, how antibodies were developed, and the symptoms are more granular fever, namely sore throat, night sweats, minor symptoms. So it follows by very long asymptomatic phase, ishobora kugera no ku myaka 5, and this is a clinical latency. Then prodromal phase, as the CD4 count drop, there is gradual onset of a variety of prodromal disorders such as weight loss, fever, persistent lymphadenopathy, oral candidiasis, and diarrhea. Then there is AIDS phase. AIDS phase. Nayo twabaramo 4, constitutional disease, neurocognitive defect, immunodeficiency, and sometimes malignancy zishobora kuza associated. So as pathogenesis is not such very complex. So first cell are antigen presenting cells, dendritic cells, nizo ziba exposed bwa mbere na mbere. Then they take antigen, of course, to the regional lymph nodes where T cells ziri. Cycle are set in so CD4 cells are infected. And they are the main target for HIV. In the days after infection, HIV is able to replicate to a very high level while the immune system learns to, that is initial. Noneho nyuma yaho hakaza kuba hari immunity. And is not able to control the infection completely, and virus replication continue in the lymph node tissue. How to kugira a bit of drop in CD4, ariko ntizihite zimanuka kuko tugira adaptation, immune system adaptation, zikadecreasinga viruses, ahubwo zikazagenda zidropinga gahoro gahoro during the 5 years, aho at one point ziba ziri munsi cyangwa ziri ku kigero cya 500 cell per during this phase umuntu atangira kudevelopinga ibimenyetso, then at lower than 200 it's then more obvious AIDS. And why do T cell die? Productive infection of the cell by the virus with the release of new progenitor virus kubera kuyikoresha cyane. Ya kabiri ni lysis of infected cell by the host cytotoxic T cell. Cytotoxic leukocyte zica infected cells. Noneho hakabaho na induction ya apoptosis, activation induced cell death of an infected cell. So these three mechanisms are the main reason of huge number of T cell death. So infection in infants is a bit more or less similar, you can read. And in Rwanda, twatangiye gutanga high active antiretroviral therapy as soon as diagnosis is made in infants. No kuvuga igihe cyose umwana abaye diagnosed, not only in infants, ahubwo ni ku bantu bose. Igihe cyose abaye diagnosed, we initiate highly active antiretroviral therapy. It limits the occurrence of AIDS. Cyane laboratory dufite ARID infection muri window period, tukagira n'uburyo bwo kudetect. Of course abana bavutse biragoye ko aba diagnostic na antibody nk'uko tubikora ku bakuru kubera ko already infected mother aba afite IgG za crossinze placenta ziri muri fetus muri newborn. A more direct way to demonstrate the presence of HIV muri aba newborn is only to detect the virus itself. Ariko dushobora no kudetectinga nucleic acid material. That is important. Dufite the direct detection of virus, dufite method direct how to targeting viral antigen. The protein 24 antigen iri muziza mbere muri serum. This is usual marker of R infection. Iboneka hagati ya 3 na 5 semaines of exposure, and once antibody appear, iyi ntabwo iba igihari, is cleared out. And detection of viral genome ishobora kuba detected within 2 weeks, which is good, and remain positive through the course of the infection. Ukuvuga ngo igihe cyose iguma iri positive viral genome. And both are the most important way of confirming infection in newborn, in infants born from HIV positive mother. Culture of viruses is also an approach, but not routinely done. It's really made for studies, for research. Markers of disease progression, CD4 count, total lymphocyte count, plasma viral RNA level. Donc, izindi marker za evolution ya infection. So hano kenshi dukora plasma viral loads, viral RNA level, which is quite reversely proportional to number of CD4 count. Ukuvuga CD4 uko zimanuka kenshi na kenshi varemia ibiri hejuru. So nibyo tureba hano. We have CD4 lymphocytes because dropping so throughout in the death, which is increased or in high in more of those with a lower CD4. So dufite HIV RNA copies per ml plasma imeze gutya. So ifite gutya, and this is always linked with a high viral load, but also low CD4 count. So nkuko twabivuze hari primary infection aho tubona ya protein yacu yitwa P24 ari na antigen iri muzaparisa mbere hano, ariko tunafite na RNA which can be seen in 2 weeks post infection, and the two are the early marker of HIV infection. Nizo marker ebyiri za early infection, HIV infection. Igihe cyose ubonyemo P24, that means that the patient is recently infected. Kubera iki? Kubera ko yamaze igihe haboneka anti-P24 zigakliyaringa zose, zigakliyaringa vuba P24 antigen. As a natural history, you can read this. You have wide dissemination, igihe plasma viremia iri hejuru cyane, acute syndrome. So entre 1 week, 3 months, immune response kuri HIV zikaza. Then hakaba curtailment of plasma viremia, zikajya muri clinical latency kubera ko immune response yabonetse irazigize. Establishment of chronic persistent infection in lymphoid tissue. So donc so the viremia can go up to 10 or 10 million copies per ml, which is huge. And it can be stabilized when the immune response ibonetse. A gradual loss of CD4 cell during asymptomatic period. Nubwo umuntu aba ari asymptomatic ariko aba ari kuluzinga za CD4 ziwe. So the effective treatment will decrease quickly the viral load. Your viral load yabaye decreased to undetectable level, CD4 automatically ziba zazamutse cyangwa T4 cell. The higher the set point, the more rapid the loss of CD4 cell and progression to AIDS. So clinical feature of HIV, symptomatic in 50 to 70%. There is a case definition which have been expanded in 93. Iyo CD4 ziri munsi ya 200 kenshi niyo uga AIDS. Besides this is infection nazo zizavugwa nka AIDS. Yo pneumocystis, pneumonia, HIV wasting syndrome, candida, Kaposi sarcoma, TB, biri common cyane ku bantu bafite HIV. Ariko kubera ko ubu ngubu dufite highly effective heart, ni nkeya cyane tubona kesi za AIDS. Relationship between CD4 count and the clinical features, kenshi usanga uko zigenda zimanuka niko pathogen ziba zifite level yo gutera ikibazo igenda iba wide. N'ubu iyi ngiyi izatera ikibazo zageze munsi ya 200, pneumocystis carinii. Mycobacterium avium intracellule byo ize hasigaye 100 cyangwa ziri munsi y'100. Cytomegalovirus retinitis ize biri less than 50 cells. So you can see all the potential opportunistic pathogen igihe zizazira ugereranyije na level ya CD4. These are some of pictures aho ugira oral hair leukoplakia, and they are more related to Epstein-Barr virus, which is a herpes virus. Uzazisome herpes virus nazo zibabaza cyane cyane. Herpes virus ziri oncogenic, zitera cancers na cancers zitera ari izihe. So you need to read all those. It is important nubwo tutabinyuzemo kuko mbizi neza ko biri clear, biri straightforward. So I expect you to read all those. Like this, Epstein-Barr virus is one of oncogenic virus.
Question.
Yes.
On the one side of when the cell starts to produce the new virus, why the antibodies destroy those cells that are producing those new virus, and they completely clear all of them in the body, the host cell? Why the immune system cannot detect the host cell which are producing those virus and destroy them?
Yeah, that is something that all scientists ask by themselves. But the problem is the dissemination. So iyo HIV yarangije ku replicating, it disseminate to all organs, including bone marrow, including everywhere. So even if immune system we are cleaning in blood, ukabona nta na detectable virus ubonamo, ariko kubera ko ziba zaragiye muri deep organ, they cannot be cleared completely. And this is a feature, kandi twongere twibuke ko zimwe na zimwe ziba zitari ku-expressing antigen. Kubera ko ziri integrated muri genome ya cell as a provirus. So sometimes they are not, kubera ko replication ibera kuri ritme, ibera kuri different level. Nukuvuga proviruses ntabwo zose ariko zihita zigira muri replication icyarimwe. Hari izizagira replication, izindi zibe ziri muri latent phase. Niyo mpamvu niyo wakoresha high active antiretroviral therapy, uzashobora gukontrolinga izi replicating, ariko izitari kuriplicatinga nta kiyongiyo izazikoraho, kubera ko ntabwo yica virus ahubwo istopinga replication. Similarly to immune system, ishobora kwica cells zose expressing the antigen outside, but because some of the viruses will just be in latent phase, nta nubwo immune system izamenya iyi cell infected cyangwa ntiri-infected. So at one stage itangire replicating, ariko already yari muri nuzi. Hanyuma iyo zamaze ku disseminatinga, it can't help. Niyo mpamvu post exposure prophylaxis tuvuga tuti numara amasaha 72 utarayitangira, it will not help. It will not help. Kubera ko dissemination ya virus iraba yabaye deep in all organ, and the success will be more or less impossible. Niyo mpamvu hari recent evidence y'abantu babiri bamaze gukira HIV babakoreye bone marrow transplant. Did you heard about that? One in US, one in UK. Those are the only two people bazwi ko babaye cleared or babaye negative from HIV, from positive HIV to negative HIV, kubera bone marrow transplant. Ukuvuga ngo babanza kugira iki, kugira kwica hafi ya cells zose, noneho bakamukorera transplant itarimo viruses. Hanyuma it was observed that it can cure. Nubwo bavuraga cancer, ariko byanavuyemo ko ababa cleared from the virus. Otherwise nta bundi buryo bwo gushobora kurinda virus iyi host yarangije kudiseminate. Is that clear?
Yes.
So tugira na zona shingles, ukayibona yaje. Iyi ni what cause this is herpes zoster, yo twita varicella zoster. So niyitera iyi ngiyi kenshi na kenshi, ubundi abantu hafi ya bose baba bayifite muri nerves, muri ends za ganglion nerves. Noneho iyo immune system droppings, it just come quickly. Kaposi sarcoma, the cutaneous Kaposi sarcoma lesion, umuntu akagira the Kaposi sarcoma, which is rare condition, but really linked with some herpes, linked in a herpes virus. Kaposi sarcoma herpes virus. Ibizabibabaza nubwo tutanyuze muri slides za herpes. You need to read all slides. So Mycobacterium avium ni Mycobacterium tuzamenya nuze intracellular, ubundi irasanzwe ni ikintu kiri common, ariko iyo immune system ya dropinze cyane kugera kuri iriya level twabonye, so they cause a very serious condition, pulmonary condition. Tukagira na cytomegalovirus retinitis, which comes very late stage. Umuntu wageze aha kenshi na kenshi return iba ari more or less impossible. Wasting syndrome, slim disease, involuntary weight loss, more than 10%, diarrhea. So drug therapy na prophylaxis, there is no cure. Icyo nicyo cya mbere tugomba kubanza kunotinga. We have many drugs now which interfere with specific step in the virus replication cycle. Uko twabivuze na mbere, ntabwo drug dufite zica virus itself, ahubwo zinterferinga na replication cycle. And tugira 3 class of antiretroviral. Kubera iki tugira 3 class zikora ahantu hatandukanye, kugira ngo mutant nkuko twabivuze iri highly variable, kugira ngo mutant zibe taken care of ku yindi molecule. Probability yuko mutant ihita igirira resistance rimwe ari eshatu ni ntoya. So iyagize mutant kuri reverse transcriptase inhibitor will be taken by protease inhibitors or nucleotide reverse transcriptase. Donc ni ukuvuga ngo uko byagenda kose iyo ugize combination therapy, so you minimize the chance of selecting mutant, resistant mutant. Iyo udakoresheje combination, uko byagenda kose uselectinga mutant akaba arizo zidominatinga umuntu ntakire. Rimwe na rimwe ya mutant wazongera gukoresha indi drug nayo ikamutatinga, so it's best kukombininga tuzabibona no muri treatment tuberculose, kugira ngo ugabanye amahirwe yuko waselectinga more mutant. Short course of antiretroviral drug may prevent HIV infection following exposure, kurugero ku bana, infants born from HIV positive mother, needle-stick injury. Niba habayeho nuze muzabikora muri stage kijomba, so you can be able to get prophylaxis. And rape can also help. And for rape, 28 days can still be valid. So vaccine prospect. So there is no yet hope, nubwo abantu bayize cyane, ariko nta hope ko vaccine yaboneka vuba. So antibody does not prevent infection. There are various reasons for this, variability of the envelope antigen. So good. Any question on HIV? ikibazo kuri retroviruses na HIV. dukore ama presentation turi always. So I will likely arrive earlier to your presentation. Okay, bye. See you Friday.
Question.
Bye.
Yes?
Can you repeat how you will calculate the marks?
What?
Can you repeat how you calculate the marks?
Which marks?
Cut and presentation.
Marks in a presentation is already 15, over 15. One, tuzaba dufite the contents. Did you cover the essential contents? Two, how did you present what you have? How did you present? Then three, how do you answer questions from audience, from myself? Is only three elements out of 5, then 15. So we have 10 questions in CAT for bacteriology that make up to 15, then 25. To get in at 25 questions za virology zizakora 25, tukagira 50, over 50. Nibyo ngibyo. Biragoye si byo ngibyo.
About the cut.
Thank you.
How about the cut will be online physical?
What?
How will we do the cut? Will it be online physical?
What? So bye. We meet on Friday. The cut is not tomorrow. The cut will be after this week. So we can clarify face to face. Like, itari clear, akibike kuwa gatanu nzaba ndaho tuzabivuga. Doris, is that clear? Okay, bye.